Good morning, everybody. We're going to get ready to kick off our Friday sessions. So for those of you still getting some breakfast and coffee, feel free to get your breakfast going and your drinks and come on in. And I might ask somebody in the back if they can start shutting the doors for me. Sean's got it. Okay, thank you, Sean. So let me just start by saying I am so happy to see all of you back here on this rainy morning. It might be raining in Rockport, but there's no place I'd rather be than with you guys here. We've had such a good time celebrating our 30th anniversary of Full Practice Authority. So very good to see you all. It's interesting to know when I think back, we had planned to have our 25th anniversary party in 2020 to celebrate 25 years of Full Practice Authority, but COVID had other ideas. So we missed out on it, but good things come to those who wait. So some housekeeping items. The exhibitors will still be here today, so please visit them. They are a huge part of why we're able to put on these conferences and have, good meals and good setting. So please visit them. There are bingo cards in your swag bag. And for those of you that go and visit every vendor and get them to sign off, if you put your completed vendor bingo card in the basket out front, we will be doing a raffle drawing today for a $50 Amazon gift card. We also recycle badges in that same area out front. So when you're done for the day, please feel free to drop off your badge and we will recycle that. And also for those of you that completed the little cards on the table, I think there's a few cards left on some of the tables about ideas and suggestions for future speakers, future topics. If you yourself have a specialty that you would like to present on, please put the info in that box. We use that to make our future conferences. For the virtual attendees, please be sure to mute yourself during the session and use the chat box if you have questions. We do monitor the chat box and we will read the questions out for the speaker when the time is right. Your CEU certificate, you will get a conference evaluation link. So for the conference itself, you can evaluate individual speakers or what have you as time goes through, but for the actual conference evaluation link, don't do that until you're finished the conference. If you finish the conference today, the live conference, and you go home and you think, geez, I got 30 days to watch the videos and I'd like to see some of the breakout sessions that I didn't miss because I was in this session, and you want to get that credit, don't fill out the link until you've watched those videos. Because once you do it, then that's what you will get credit for. We still have the volunteer committee sign-up sheets out front. If you are interested in participating more with the MNPA, becoming more involved with the board or the organization, please consider being a volunteer. Volunteer legislative committee folks, professional development, public relations. The great thing about being a volunteer is you're not committed to attend every meeting. You can sit in when you want and help participate, but you're not beholden to it. It's just a great opportunity to network and help us get better. Sign-in sheets. Most of you have already signed in again for today. You don't necessarily have to do it, but if you want, you can check box that you were here for Friday. As long as you fill out the link, that's where you get your credit for being here. Please make sure you save the date for our fall conference, which will be November 7th at the Sheraton in South Portland. And then for 2026, our annual spring conference will be April 15th through 17th here at the Samoset. So make sure you get that time off. There are still copies of the book out front. That's the historical compilation of Maine's nurse practitioner journey to full practice authority. It's a great book. You're going to see a lot of people you know in that book. It's a great read. So go ahead and feel free to pick that out front with some swag. I also have 3 people that won an item at the auction last night that still need to see Amy Marsden to pay their tab, or Megan Woodman. Megan's in the back. See Megan, she can help you with that. And the 3 people are Rachel Pacone. Are you here today, Rachel? If anybody knows Rachel Pacone, let her know. You know Rachel. Okay, so Jen Mygatt is M-Y-G-A-T-T. Jen, if anybody knows Jen, have them connect with Rachel. And then Kayla Thompson. If anybody know, I think Lori knows Kayla, so we'll find those three. So they've got some items to collect. With that, I would like to introduce our first speaker of today, CJ Spotswood. Spotswood is a psychiatric mental health NP, is a board certified psychiatric nurse practitioner with his practice in Central Maine. CJ is a third generation nurse with over 25 years of psychiatric nursing experience. CJ is the author of the Microdosing Guidebook, published by Ulysses Press, and has published in the Journal of American Psychiatric Nurses Association and Clinical Case Reports. CJ attained his graduate degree from the University of Southern Maine and is a graduate of both Psychedelic Today's Navigating Psychedelics for Clinicians and Therapists program and the California Institute of Integral Studies Psychedelic Assisted Therapies and Research program. CJ is also the principal psychiatric clinician for Remap Therapeutics, working with psychedelics for individuals with chronic pain. CJ has been researching and teaching on psychedelics since 2018, having presented for various conferences, including the American Psychiatric Nurses Association, the National Conference twice, the Psychedelics and Pain Association, Cluster Busters, and he also teaches master classes for both Psychedelics Today's Navigating Psychedelics Clinicians and Therapists education program and their year-long Vital Psychedelics education program. He also co-authored Psychedelics Support's 9-hour CME accredited education program entitled Understanding, I am not going to be able to say that word, psilocybin effects, neurobiology, and therapeutic approaches. And he works with clients that are working with underground practitioners before and after psychedelic sessions from a harm reduction approach. And with that, I welcome CJ.
I'm going to apologize. My throat is about shot by allergies, so I hope everyone can hear me okay. No problem there. So thank you for the great introduction. Thank you for having me today. I'm CJ Spotswood. I am a psychiatric nurse practitioner. It's been really exciting as I've done this talk over time because I've gotten to do this at so many different and interesting and just weird conferences. It's just, it blows my mind where it's gone. So assuming, okay. Just kind of as a CYA for all of this, this is intended for educational purposes only. I am not here to condone the use of illegal substances or the purchase, sale, transfer, or otherwise. It is not intended for substitute for professional medical advice. And I will be discussing the off-label use of non-FDA approved substances, which was actually kind of an interesting thing. The first time I did this talk, they had no idea where the hell to put this, because I'm going to be talking about things that typically don't get talked about. So that was what we landed on, and I've been doing it since. I have no specific conflicts to disclose. With the about me, the great introduction, it was all kind of there. I just wanted to start off, say, I know this is for many people, it's a interesting and scary thing I might be talking about. People don't know how to kind of put it there, don't really understand the full part, which is why I love having this conversation. But with nursing has been entwined with psychedelic studies when it comes to forever, really. I was going to say in medical use, but oftentimes, even in indigenous use, the healers were some sort of medical professional, the nurses, the healers that were there. One of the earliest talks that was out there, there was a nurse in 1994. Her name was Laura Berg. She was working with Rick Strassman with DMT. I'll be talking about that a little bit, the DMT. But when she was talking about it, it was talking about what she referred to the nursing she was doing as being a flight nurse, meaning that she's there while the person is going on a trip, holding their space while they're gone, and being that tethered to the ground into reality. So when things came up and wanted to talk, or someone just wanted to um, where am I? What's going on? She was there. And if we think about it as nurses, how often do we do that already? You know, with individuals who might be mentally altered from substances, but also, you know, when someone might be delirious, loss of consciousness, things like that. So I check my bias at the door with this. I am kind of biased when it comes to uh, being vocal about nurses working in this space because it is so familiar for us to be able to sit there and work with someone while they're altered and just not typically there. 1 second. I'm old school, so I don't trust technology, and I've done so many talks where nothing worked. I'm kind of married to my pen and paper doing notes. So yeah. So one of the things I want to kind of mention, and it's kind of a controversial statement to begin with, when we look at psychiatric care, all of the current pharmacological treatments for psychiatric care are merely palliative attempts to address symptoms and reduce the experience of suffering. We don't cure people. The medications that we have don't cure anything. They help them cope with their life and be able to work with what's going on. But none of these things are medications like doing radiation or chemo, where, you know, we kill the cancer cells. We have people being able to cope with what they're doing and what they're doing in their life and being able to live that way. And sometimes that's kind of a tough pill to swallow. When I've spoken about this before at a conference, so people were kind of got really up in arms for a few minutes till we started talking about it. So I just want to kind of put that on the table to start. When we think about treatment for mental health and psychiatric conditions, if we take into consideration the research that shows that when individuals engage in therapy, they 30% end up having better outcomes compared to just having medications alone. And when we think about that, you know, it might not be uh, formal psychotherapy. It might not be, you know, CBT, it might not be EMDR. It might just be talking with people and being present and being able to have those conversations and people being able to be heard. But I think that's a big number when we think about that 30%. That's why I always encourage patients to kind of go and do that and be a part of that and you know, being an active participant in their treatment and actively participate in what they're doing. So when it comes to the word psychedelic, what does that mean? It's a neologism, so it was a word that was made up, combining the two parts of psyche, meaning the soul, and delaun, to make visible, to reveal. So what these substances do is they end up starting to reveal these parts of the body, these parts of the mind that people might not be completely in touch with. Leads to what's referred to as mind manifesting. And we think about like, what does that mean? You know, some of the stuff that people start talking about and things that kind of arise during some of these sessions. Sometimes there's things that people aren't even aware of or aren't fully conscious of, or don't want to have conscious and just kind of have suppressed it, and all of a sudden there it is in their face, and it's part of that pre-integration. Some of these terms I will get to, but kind of getting someone prepared and understanding what they're going into doing. Another word I often refer to is the word of entheogen, and those are a class of psychoactive substances that induce a spiritual experience aimed at development of the sacred. So what that means is some of these medicines reveal that healing inside of us. Part of the training when I did with the MDMA what we refer to is that inner healing intelligence. And it was interesting the first time when brought up, and one of the team of that is a husband and wife. He is a doctor. She's a nurse. She's been working with that for a number of years. What it refers to is, if we think about, and he was an ER physician, what it refers to is when someone ends up getting into an accident or they get a cut, they come to us, we might stitch that up. We might put a bandage on it. We might do all of those things, cleaning it and making sure that they have the best outcomes from it. But the body heals itself during that time. We're just setting up that playing field to give it the best chance of having that healing. But when the clotting happens and all of that, those are all physiological changes that are going on. And these substances don't go in and fix, they go in and allow people to then work with it. A couple of common terms I will be referring to during my talk here is I'm going to be using the term LSD. That is often referred to as acid. Another substance I will be referring to is psilocybin, which is often people know as mushrooms, magic mushrooms, shrooms. Another substance I will refer to is MDMA, which is also known as ecstasy, Molly, these other things. And there might be a little bit of a talk about with DMT. DMT is the active chemical that's in ayahuasca and toad venom. If we look at here, these are kind of what some of these might look like. In the middle, there's also peyote. I don't really cover that, but it's one of the main psychedelic substances that are out there. People might wonder why I'm even bringing that part up and putting these terms out there. First couple times I did this talk, the first question when I opened up the Q&A, they go, so the thing that you were talking about for the last hour and a half, and you said psilocybin, is that mushrooms or is that? Yes, that's mushrooms. So I just give everyone kind of a even playing field. And when we look at these psychedelics outside of the MDMA that is on there, most of them are what's referred to as classic psychedelics, which mean they work on the serotonin 2A receptor. So some of these, when we look at that, what that means is they activate the 2A receptor, which then induces the psychedelic trip that's going on, which is different than antidepressants and other substances that people may be using. A little bit of the brief little history and just to kind of put it out there, like I said, these have been substances that have been used for a long time, number of years. LSD psychoactive effects were first discovered in 1944. Inadvertently, anyone wants to go into reading a very interesting story of that. Long story short, basically, Albert Hofmann was working as a chemist in Switzerland during World War II and was working with ergot and different compounds. And he was looking at one of the compounds when they were using it was also used for anti-bleeding, often with hemorrhaging and stuff with pregnancy. And he accidentally got some on his skin. He went home not really knowing what was going on and things were feeling weird. A couple days later, we're trying to figure out what was that's happened. So he ingested what he thought was a small, tiny amount of LSD and ended up going on a very interesting journey that he had no idea. If anyone can think of 1944 Switzerland, this is also right in the middle of World War II. So he rode his bicycle home. It's referred to as Bicycle Day, and we actually just had that about 2 weeks ago. 1947, first papers were published on LSD's effects in humans. 56, the term psychedelic was coined. In 1957, the term magic mushroom was coined by Life magazine, which may be a very interesting place to see that. But what happened with that is it really changed history after it kind of came out. After reading about that in Life magazine, I was Wall Street banker named Gordon Lawson. He went with his wife and they went down to Oaxaca, Mexico, where he had heard people were ingesting these mushrooms, and they ended up taking pictures of a full ceremony with it. And when it went into Life magazine, people caught word, started learning about it, such as Bob Dylan, Janis Joplin, Pele, John Lennon, the Beatles. Why I say it kind of changed everything, because it became a tourist trap a lot of people went to, people started learning about, wanting to understand what it was. But we just simply look at the Beatles, you can see a big difference from the White Album to Sgt. Pepper's. Something happened in the middle of that, and it was this, they found LSD and what the effects of that. There was a conference in '59 looking at the use of LSD psychotherapy. 1962, there was the Good Friday experiment with Walter Pankey. During that time, they were looking at trying to figure out what was going on. They realized that this was unlocking very mystical, but also very interesting things that were going on. They didn't know what they were going to kind of necessarily do with it. The thing with Walter Pankey was he was a doctor of theology at Harvard, and he was doing this as a dissertation, and they ended up going and dosing half of the people, the other half had a placebo in the basement of the Marsh Chapel in Boston on Good Friday, the holiest day for Catholics, during the ceremony. And it was very quick to understand during that time period who received the medicine and who got the placebo. And the part I left out was all of the participants in here were theology students trying to figure out God, spirituality, what am I going to do with my life? And it got a little weird for them. It is probably one of the best dissertations I ever read. But the thing with that, like when we look at this, is not, these are substances that were being researched during the time by prominent universities. Yeah, I know when I first started getting into this scene a little bit, my father's a nurse, and he's like, so I see all this stuff you're talking about in schools that are doing the research. Where is this going on? And I was like, oh, a couple of big names, Yale, Harvard, Columbia, UC San Francisco. And he's like, oh, yeah, it's not such a community college. These are prominent universities. So during this time, when we look at during the 60s and into the 70s, these substances were fully legal during the time. It was very interesting. Walter Pankey, the gentleman with the Good Friday experiment, he urged at a conference in '67 that the dangers of abuse must not be allowed to cloud the solid scientific evidence showing how when the psychedelics are administered in controlled settings, permanent adverse reactions are rare. And he urged that we need to really look at this research because he kind of saw the writing on the wall that something is going to probably happen. It's not going to be allowed. During this time period, when they were looking at this, during the 50s and 60s, LSD psychotherapy was used by over 40,000 patients. Several dozen books were published. There were 6 of these international conferences that were occurring, and over 1,000 clinical papers were published during that time. So when we start talking about, we start hearing about safety and knowing what's going on and all of these things, this isn't new. These are things that were very well researched and then shut down. It was in 1970 where everything changed when Nixon signed the Controlled Substance Act. Contrary to what some people might believe, they think that was because of safety and worrying about people jumping off of roofs and dying. But one of Nixon's top level people had said this is a way to try to control people. If we think of 1970, during that time, we were in the middle of the Vietnam War. People had listened to Leary and doing the turn on, tune in, drop out, which didn't mean drop out of college. It meant dropping out of society, dropping out of kind of that system that was going on. It was very hard for the government to end up controlling people and getting people to go across the world to kill other people that they've never met. When some of these substances have unlocked pieces where people are realizing we're all one, we're all the same, we're all interconnected, all of these things. So as a way of controlling, they realized they couldn't stop it without banning it, which when, if anyone wants to go into the history of drug prohibition and looking at much of it, most of that is done for either racist reasons to control a population and being able to lock people up, or take away some of these other pieces that go against those norms of what they're trying to push. So when that happened, 1970, there was a signing of the Controlled Substance Act. What we saw was these substances were put into being what's referred to as Schedule I designation. I'm sure everyone in this room knows what that means when it comes to the DEA. What that means on paper, and I say that because a lot of what I'm going to be talking about moving forward is in contradiction to this, but means that there are high potential for abuse. There's no current medical use that's accepted, and there's a lack of safety for use with medical supervision. Despite when we started looking at with psychedelics, that these have been overall safety-based since 1940 and even longer for indigenous use for much of these substances. When we start looking at as we've done more research to kind of understand, we've also seen the anti-addiction properties with this, which makes it really hard to say they're addictive. And what was interesting is there was a psychiatrist, there was a doctor named Stephen Pollack in 1975. He, interesting cat. One of the things that he had said when he had published, he said, psilocybin has properties making it very efficacious for psychoanalysis and psychotherapy, and he predicted that it would be legalized for such in 10 years. That was 1975. That was 50 years ago, and now we're starting to explore this again. We lost a lot of time during that period to do better research and understand it better, but I mean, he called it at that point. The interesting thing with Pollock was he was working on this as a mushroom farm, trying to get this up and going. He was murdered at one point. There's a lot of dirty background understanding of it. It's still a cold case. It's an interesting story there, but we see these histories of trying to shut down when these conversations are going on. When we look at that anti-addictive property that comes with these substances, we look at rat studies that have been done where they've given rats free open use to LSD in their water. The rats that went and started drinking this, they didn't come back for the water after they got dosed. They just kind of hung out and kind of chilled. Sometimes they might have came back with a little bit of tie-dye listening to the dead, but they weren't really coming back and being a problem or wanting that water. They weren't craving that feeling because it was just so intense for them. A little bit more of the history here. When we started seeing MDMA was Schedule I in 1985. MAPS was formed. I'm sure people have heard about MAPS with the MDMA trying to be legal in the last year. In 1990, Rick Strassman was able to work with DMT. It was the first research that was being done since the 70s when it was banned. That was the one where I'd mentioned the nurse that was doing the flight nursing. She was working with Rick Strassman. It was her telling these stories that were there. What we also saw was Congress amended the American Indian Religious Freedom Act, RFRA is what it's often referred to, showing and saying that people will be able to use these substances in their indigenous use, which is where a lot of people have been trying to kind of skirt use and get around it in recent years. And in 2012, the FDA allowed for breakthrough therapy designations, making it kind of streamlining substances being able to become FDA-approved drugs, which is where the MDMA was, how they were trying to get it legal last year until that failed. And I'll talk about that probably here a little bit, that with how that failed. But really, when we start looking at what's going on here, it's the research is out there and people don't understand that. So MDMA, what is MDMA? MDMA is not a classic psychedelic, as I've mentioned before. It has more effects than just working on that serotonin 2A receptor. What MDMA was once referred to as penicillin for the soul by Sasha Shulgin. It was also used underground up until it was banned in 1985 for a lot of couples in psychotherapy for people. Psychotherapists would often refer to it as the name Adam because it brought people back to the primordial state of being, that age of innocence that's there. It was used a lot, actually, before it got banned. One of the part of the when it was going to be emergency listed, a large number of therapists and people that were working with this, doctors, pharmacologists, etc., went against and trying to fight for it. And during that meeting with the courts, they determined that this sounds safe. We should probably put it into a bifurcated scheduling, meaning it's illegal except for during use for therapy, which the FDA didn't listen to their own judge and decided we're just going to ban it outright, which often doesn't work well for people. Awesome. So as I said, it was legal until 1985. Not a classic psychedelic, it does work on that, but also the other things that it works with is it also increases oxytocin, prolactin, and cortisol. We start thinking about those substances specifically. What do they do? When we start increasing the oxytocin, prolactin, things like that, it increases empathy, trust, caring, makes people better to accurately perceive their emotions. It increases that therapeutic alliance that people have. People become more gregarious or more fond of being around people, and increase sociability. It shuts off those parts of the brain, and that amygdala, getting rid of that fight or flight. So what people are able to do when going into a MDMA session is it shuts off that typical response that's there. So while that's going on, they can start accurately understanding their emotions. They can start understanding what is going on with me. They can kind of look at those things differently without all of that fear going on. And part of the MDMA training and way it is while people are doing it and sitting with therapists and they're not, the idea is you're not going in and starting to talk about these substances and just saying, okay, now that you're a little more flaccid and you're able to talk about this, let's do it. You wait until the individual starts bringing it up, things that they haven't talked about maybe their whole life or to this level. And every time, and if they don't bring it up, you don't, and you wait till the next time. But in all of the research, all the examples when people are doing it, in less than an hour, people start talking about those things that they haven't been able to talk about. So it gets people into this optimal arousal zone where people can start thinking about this traumatic event. They can start looking at what happened, how to address it. Leads that heart opening where they can start healing themselves and have that connection, empathy with these strangers that they may have met a few times in that pre-integration to get to know and trust them. Be open. The exact opposite of what PTSD causes for people. People are able to start looking at things and addressing things in a way without being fully aroused. Now, if we think about other substances that are out there that shut down, that people can start getting in touch with it, you know, alcohol, benzodiazepines, things like that, they all make people tired. And people can't accurately assess what's going on. This doesn't do that. It just shuts it down and quiets that mind a little bit. And one of the best quotes I saw is people were able to, one person said, I was able to understand what was going on and feel things in ways I have never been able to do that before. They never were able to process what their experience of what happened. And now they were able to. And I can tell you, when you start seeing someone who've used this and start coming out of it and being able to talk about things, it is absolutely amazing to have and seeing what's going on. So with this, the early research in the phase 3 clinical trial, what they found is double-blind crossover. All the participants received psychotherapy at the same time as they were getting the treatment. The first stage of people, after getting the first dosing there, 83% had improvements and decrease in their symptoms of PTSD versus 25% getting a placebo. One of the things to think about here is, that 25% with the placebo, people were getting improvements. Even though they received the placebo medicine, they were still engaging in therapy. But 83% of people were getting improvement over placebo. We don't see this in healthcare. We don't see this in psychiatry. And when they did the crossover study afterward, so everyone, even the people that received the placebo, they had the same improvements that were there. And these are individuals with PTSD. The clients that were here often had 90% of them had living a lifetime with suicidal thoughts. Many of them have been in treatment for over 20 years, working on their PTSD symptoms, both psychotherapy and pharmacological. And the average person had been on 4.5, I'll say 4 or more SSRI medications during that time to get treatment. In a couple of sessions, in a couple of afternoons, and these symptoms are gone. People are able to have those improvements and being more present in their family, talking with their family, and being there. We just don't have that when it comes to standard treatment that's out there. So as a result of this study, what the FDA did is they ended up making it a breakthrough therapy status, meaning that it's going to be sped through. There was a special protocol assessment. They said that if we start hitting these points and you hit the marks, it's such an improvement over what we have, it will become FDA approved. Unfortunately, that didn't come to fruition. When they did the stage 3, the phase 3 results, after 3 sessions with the drug, 32% no longer. So phase 3 being the larger group, more people that were doing it. It was a worldwide study in numerous places, US, Canada, Europe, places like that. 32% no longer met criteria for PTSD when they got the placebo with therapy. 67% no longer had with the MDMA. And it was touted that, according to the New York Times, there's nothing like this in clinical results in neuropsychiatric disease. And agree with that. Yeah, it's absolutely amazing when we start seeing what people were having. Unfortunately, it was not FDA approved last summer, much to the chagrin of a lot of people. We don't know exactly. There was a lot of talk of the results. The studies weren't conducted in a certain way. There was also some political reasons, and I'm not going to really go into discussing all of that, but it was a lot of people thought this was going to happen And it really just changed a lot as a result. It's very difficult. And I think about what, with the individuals who were banking on it and now feeling worse because they're not going to get this treatment after they've seen these results being, everyone talking about it and looking forward to it. So it's really, it's unfortunate. I'll just leave it at that. When it failed, like I said, these concerns that were there, I'm hoping that we're going to start seeing it being re-explored. But as a result, I think we're going to see other substances become legalized before MDMA. LSD is a catalyst or an amplifier for the mental processes. If used, if properly used, it becomes something like a microscope or a telescope for psychiatry. This is a quote from Stanislav Grof, who is a psychiatrist. He is still alive. He's in his 90s now, and he has sat in thousands of LSD sessions in his lifetime. And some really interesting books that he wrote about these substances and what he saw. But what he was seeing is you can get into these parts, and the point of what he's saying is you get into these parts of the brain that no one talks about, no one can explore, no one's really in touch with. So LSD assisted psychotherapy for individuals with terminal cancer. What they found was 71% had a dramatic or profound moderate improvement. 25% had what they referred to as having profound experiences. And statistically significant improvements in symptoms of depression, anxiety, fear of death, improvements in their pain sensations, and less feelings of isolation. Some of the feelings of, oh, this is end of life. People are talking about that existential dread. What's happening next? Where am I moving forward? And these substances really help them kind of get through it and understand things a little bit differently. The thing with LSD is it can be a rough trip for people. And I mean that in onset usually takes about 20 to 90 minutes. The peak starts coming on about 2 to 4 hours, but it can last 8 to 12, 18 hours. That's a long day. That's a long day for someone who might be the walking well, let alone someone who's, end of life, chronically ill. This is a really interesting story when they're looking at the use of this. And it's not exactly by modern day standards. One of one of the doctors that was doing a study back in the 60s for end of life, there were individuals on this cancer ward, and when he was visiting them, he reached into his pocket, pulled out his bottle of LSD, had the patients put out their tongue, dose them, leave the room. And this is what it was legal at that time. But the individuals, when they had this and they went back and found out, how are you doing and how was this? They said it wasn't terrible. They started having improvements in their pain and needing less pain medications as a result. They started having in touch with individuals and in touch with these parts that were going on. And they referred to it as having an oceanic boundlessness that was there. I don't know. I mean, someone's dying in a bed in a cancer in the hospital, and all of a sudden they get a little reprieve from that for a little while. I'm not saying dosing people in the will and they knew what they were going into. What I'm saying is these are things that could be, if available, used for these things for individuals to, if nothing else, have some improvement in their life. So because of LSD being such a long half-life and being such a long and challenging trip, what we find is a lot of people start looking at psilocybin. But I always like to talk about the LSD piece because it is something that's been studied and understood for thousands of papers that were there. It's more or better known for the research that's been done on it back in the day versus now. Psilocybin is a much shorter trip. Starts peaking about 30 to 60 minutes. It's the onset, peaks about 1 to 2 hours. Duration, average of 4 to 6 hours. Sometimes it can be a little bit longer for people. Sometimes the trip is a little less challenging for individuals as they're doing it. It was once referred to by Albert Hoffman that LSD is like an atom bomb, but psilocybin is more like a conventional method weapon of war. It's a little bit more tolerable for people. What it does is it starts shutting down some of the brain. It starts having some of these interesting things that are going on, but also it can lead to a rapid and sustained symptom reduction of anxiety and depression. In a similar study with life-threatening cancer, what they found was 83% had a remission from their depressive symptoms 3 months out, compared to 14% that received a placebo. And 58% said that they had less anxiety as a result, compared to 14% in the placebo. What's interesting is what also kind of look at with the 6-month follow-up with that is we look at standard treatment, the SSRIs. SSRI research is, conventionally what we know is about 68% report improvements in there with those substances, 83% with depression, and this is with having a couple of trips. 52% of individuals said it was the single most powerful experience in their lives. We think about those powerful experiences that people have in their lives. Typically, people will talk about the birth of their child, their wedding, death of a parent. Yeah, 52% of people that ended up going on a trip with psilocybin with life-threatening cancer said, this was the most powerful experience in my life. 70% rated as the top 5 most spiritually or personally meaningful experience in their life. And 87% said they had an increase in their life satisfaction attributing to that experience that they had. Now, let's talk about Abraham Maslow just for a quick minute, and everyone knows who he is, Maslow's hierarchy of needs. The interesting thing, one of my mentors when I was going to CIIS, Bill Richards, who's been doing this psilocybin research in the 60s and the 70s, and came back once it became legal again. He was a TA under Abraham Maslow. And Maslow had said, and there's no research, there's no talk that Maslow has ever tried these. Part of it was he also had a cardiac condition, so he didn't want to test that as a part. But what he said was, if maybe we give this psychedelic, such as psilocybin or LSD, to someone to have a peak experience in their lives, and in the right circumstances, perhaps we wouldn't need to wait for them to happen in good fortune. Perhaps we can induce this on a personal level. So what does that mean when it comes to a peak experience? This is like a end of life diagnosis. It might be a sudden death. It might be that near-death experience that someone had. It could go, I don't talk much about woo-woo, but I love the woo-woo. Someone could have an alien experience, like something that just at that moment just changes how they are. And if we can induce that with these substances, what does that look like moving forward? So when we look at psilocybin occasioned mystical experience, in theory, the ingestion of a large dose could model quantum change moving forward. And in a study where they've looked at this with a high dose group of people, when they've induced this from the psilocybin, improvements when I say these improvements, look at the P-score here. I mean, that's 0.001. How often do we see that with other research that's being done, you know? But these improvements were attitudes in their life, attitudes in their self, positive mood changes, having more positive social effects, increasing their spirituality, and having more improvements in life satisfactions in their life. When we also look at this, you know, what is being done, these changes with this being induced, the longest study out was a follow-up of 14 months, which people still had these improvements. In talking with the researchers informally, because they had never published it, they were seeing these numbers 3 years out as well. Sometimes, you know, it's kind of that experience kind of diminishes over time as people become, you know, forgetting about it or less, you know, life happens. But when they come back and think about it, it really is still having that. So that mystical, that single most meaningful experience, what they found, there was a study here, where it says high dose, people were getting a high dose. Where they found standard support was people that were, you know, getting that individual psychotherapy in the moment. And there's also the high support numbers. So people were doing more improvement there. Ultimately, what this slide ends up meaning is it meant less about the psychotherapy and less of the support that they were getting. It was really that high dose that was there that was really the important piece of getting this improvement. What in that with the high dose individuals, irregardless of the support that they were getting, in that high dose, 84% with standard, and 84% getting standard support and high dose had those most personal meaningful experiences, as opposed to 12% who got the placebo or the low dose that didn't have the experience that's there. When so it was a couple years ago, 2021, it was the first study that was published looking at a head-to-head trial of psilocybin with escitalopram. What they found was 70% of the individuals had improvements, as opposed to 48% that had that with the standard escitalopram treatment. What they found were for remission rates in the follow-up moving forward, 57% still had a remission 6 months out versus 28% that were using the escitalopram. These individuals, the average age was 41 years old, and the average length of time that people were battling their depression in the psilocybin group, they were having diagnosis for 22 plus years on average. Excuse me. And the escitalopram group were 15 years. So individuals were doing the treatment and for the first time in 20 some years having these improvements that were there. Now, when we start looking at the study, I really encourage people to read it and read more than just the intro, the beginning part, because when you read it, I think there was a little bit of pressure with the publishers to not be too excited about, which I love that fact. But when we start looking at the numbers that people were having, they were talking about, it says that people had the same amount of distress, side effects, adverse effects. There's the same percentage of it. And with that, with the psilocybin group, people started reporting that they had improvements in their ability to cry, feeling compassion, feeling emotions, feeling pleasure, feeling less drowsy. When we started looking at standard SSRI medications, how often do we hear patients coming back and saying any of those things? With the escitalopram group, what the participants reported was having more anxiety, more side effects such as dry mouth, having more sexual side effects. How many people have come off of their medications? I mean, you guys, your patients saying, I'm not doing it because of those side effects that I've had. and having more of a blunted emotional response. So people are feeling feelings and crying for the first time in their lives that they were having that. And when we look at the side effect profile, yes, the side effect profile that people had adverse effects, people were having, oftentimes comparative wise, the people that were having side effects with the psilocybin, they reported having a transient headache the night after, which was remedied with Tylenol, as opposed to something that they're dealing with daily for weeks or months as they're trying to get their escitalopram up to a proper dose for themselves. The slide does say that we were waiting the 6-month follow-up that was published. After that, everything got kind of slowed down. There's an event, people might remember, COVID, that happened. Time warp that happened there, but with that, people still had those improvements moving forward in that study as well. I do feel, without reading the whole thing, it does feel like some of the effects were kind of diminished a little bit, just for the fact that same side effect profile, the numbers, if we start looking at, the percentage wise, there's a big difference between that 70 and 50%. But on the headline of it is no better than, which I think there's a little bit of a better response that people are going to say, I feel a little bit better about this. So I keep mentioning this mystical experience. What does this mean? What is it? Post-session, people will do is what's called a mystical experience questionnaire, MEQ 30. This paper has been used since the beginning. It was the first use actually was in that Marsh Chapel experiment. This was written by, I mentioned Bill Richards already. He was one of the individuals, and also Walter Pankey. They came up with it. And over the years, they've changed it a little bit, but it is statistically shows how much of an experience that someone may have had when they did this. So what does that mean when they're having it? The mystical experience looks at people that have had feelings of internal unity, external unity, noetic feelings. The noetic feelings being that they're feeling oneness, connection there, having this sacredness that's there. Other factors we look at: having increased positive mood, feeling of amazement, tenderness, peace, tranquility. Factor 3, transcendence of space and time. They lose the sense of time, may lose the awareness of who they are in the sense of being during that time period, or feeling outside the realm of time, space. And then factor 4 being ineffability, a sense that the experience cannot be described by words, and doing so would not do it justice if you try to explain. And feeling difficult to try to explain that to others. There's a great meme out there. I love it. I wish I had a part of the slide where someone draws a picture of what they think their experience looks like, and then when they come off of it, it's just scrabble. It doesn't make any sense. But when talking with individuals who have had these experiences, many of them will try to explain it, but individuals who have also had these experiences go, it's okay. I get you. I understand. I understand where you're coming from. I understand that this is things you can't put into words. So we would do this MEQ as a follow-up and looking at how much did they end up tripping, how much of an experience did they go out and have. But also with that, it doesn't mean that someone that has a really high versus someone that might have had an experience of being low, it does not matter the amount. They can still have those improvements even if they don't have a full noetic type of experience that they're having. So how do these medicines work? I talk about the classic psychedelics a little bit. What they do is they act on that serotonin 2A receptor. Here's a picture of looking at the different parts of the serotonin system. So with this, The top is individuals who are using standard medications. The standard medications, SSRIs, work on the serotonin 1A receptor. We start seeing, ultimately we start seeing where things start shutting down a little bit in the brain. The limbic response goes down. We start seeing symptom reduction in stress, impulsivity, aggression, anxiety. So one of the stories, how I always explain it with my patients is the SSRIs push down depression, push down anxiety, push down those feelings a little bit, which then lead to having more patience, more resilience. The trade-off is often having more blunting in their emotions, but they become more tolerable of that stress that's going on. The classic psychedelics working on that serotonin 2A receptor has that same action that's going on. It pushes down that rigid thinking where people can't think of their way of thinking things differently, and less feelings of pessimism. And as a result, also we start seeing improvements in neuroplasticity, becoming more sensitive to their environment. And I mean that in a good way. They start being more aware of what's going on around them. They start having more an ability to learn and unlearn behaviors. They can kind of shut off those parts that how they think in ways that they may not see an out. And they become more adaptable and change. Ultimately, both of these lead to the same outcome of having less depression and more increased well-being feelings, but it's a different path to get there. So how does that work? What it's doing is it starts working with that default mode network. So I mentioned earlier with the amygdala, these substances will end up shutting down those parts of the brain that's going on, that fear response. These two pictures where we start seeing here, specifically that picture that's on the bottom, these are the connections in the brain and the parts of the brain that are speaking to each other. On the left, the picture on the right is what happens when these parts of the brain start talking to each other after the substances are ingested. So parts of the brain that typically don't talk and converse with each other start talking. They start having this response. And as that starts happening, that's when we can start learn and unlearn behaviors, and we can start thinking of things in a different way, in a different manner. And these effects are not just when it's happening, it's following the weeks and months afterward. It shuts down that part of the brain that's that gatekeeper that's there, that part that makes it so that way we filter what our thoughts are. So we think about what the default mode network is. It's that top of the brain hierarchy. It usually inhibits other parts of the brain. So it consists of like the prefrontal cortex. I believe there's pharmacology hours here. This is why I have to put this part here to get a little more in depth. So it starts shutting off those parts of the brain with the parietal lobe and the cingulate cortex. And what they looked at in some of the research with the hypothesis is the increased blood flow to parts of the brain stimulate what's going on. When they've done these research under fMRI conditions, it wasn't also where it was parts of the brain was getting more blood, parts of the brain were getting shut off. So kind of off system, a reset, rebooting your computer perhaps, same idea. So with that default mode network is the part of the brain the parts of the brain that are going on when we're passively thinking, mind wandering, it might be when we're passively watching TV, not actively involved, and just kind of doing these things. That's that default mode network, as opposed to the task negative network where we have goals, tasks that we're starting to do, that social working tasks. So it's when the brain is thinking passively. But also the idea is it kind of goes to the brain. The default mode network is very active with kids. That's the part that has that childlike thoughts that are going on. And we start learning as we get older. Our brain doesn't want to work hard. We want to have, things that kind of, we can assume this is the way it's going to work. So we start getting these algorithms in our mind of, thinking less, we have to think as actively that's there, and it kind of shakes it up and breaks that. When we think of kids and that childlike magical thinking that they have, kids say the wildest things. I want to be able to fly. I want to do all of these these things because in their mind they can do that. We lose that as we get older. Also, as trauma, things happen like that. All these other things turn into where we can't do it. We think about, depression, substance use, anxiety. I'm not going to say that DSM is the best thing that's out there, because when we start looking at how many of these symptoms have these overlapping pieces that are there, how often we see patients that, go to 10 different clinicians and have 10 different diagnoses there. That's why we treat the patient when we treat what's going on. But we start having these algorithms in our mind that we can't do things. This shakes that up and changes those thoughts so that way things are more possible. When someone is depressed, you start saying, well, why don't you think about doing this and doing that? Some of those things are impossible for them to even comprehend at that point. This kind of is a little bit of a dose of hope. They can start seeing things in different ways, which goes back to that slide where I said with the 1A and the 2A, the 1A pushes all of this down. By activating that 2A, it activates where people can think of things in a different way, that unlearning and unlearning and doing these management things that are quite different. With the default mode network being lit up in the activation of that serotonin 2A, what it leads to often is ego dissolution. It breaks that thought of who am I, which might not necessarily be a bad thing, when who am I is someone that sees themselves as just being depressed or having a substance use disorder or dealing with all these things, and then having what society puts on them in that role and what they think that they're supposed to act. This changes all of that for them to be able to see things differently. And yes, I'm going to allow time for Q&A with this. So when it gets into this phases of therapy, psychedelic therapy, what we start looking at is there's 3 phases. Typically, there's early preparation. It's where people are talking about, I want to go into this. Early preparation starts when they make the conscious decision, I am going to look at going to do this. So the early preparation starts going, they start talking with the individuals, they start coming up with a plan of what they're going to do, how they're going to do it, what is the circumstance around it, where are they going to be, etc. Second phase is that psychedelic session where they're actually ingesting the substance and going on that journey. Oftentimes, this is more than one journey that people will have. They do it a couple times. And part of that is the first time and they've never had that, they're starting to get into unlocking into parts of the brain that they've never been before. And it gets a little weird at times. And then there's that post-integration session where they start coming out with the information and kind of, what am I going to do with this? Where am I going to go with this? So oftentimes, with the psychedelic therapy, telling people, while you're in there is not the time to start trying to figure out meaning. Right now, as you're going in there as an investigator, as an explorer, explore those parts of the brain, explore what's going on in there so you can bring it out. And when they're doing that, the person that's sitting with them, the facilitator, might be taking notes. They're there grounding them if they have any challenging experiences, but kind of like bringing stuff out so they can talk about it later. That's where the therapy, because it's too much to try to process when their mind is altered during that state. So it's a couple of things when it goes in with what people are doing, we often refer to as what is set and setting. So the set is the mindset that the person is doing, the mindset of what they're looking at. So in that pre-integration, when they're doing it, we start talking about what is that set going to be? What is their expectations? What might be their motivations? What is their intentions that they're going in to do? We talk about like the person that's sitting with them, concept of the nature of the experience, talking about what's going to be, what they might experience a little bit, and having agreed upon goals, coming up with programming of it and specific techniques for the guidance. They start looking at what is there. And then when we have the setting, it's the actual environment that the people are doing. It's that personal, physical experience, that interpersonal stuff going on, and having concrete experiences under when the drug is there. So, giving them, letting them know, I'm going to be sitting with you. I'm going to be here. If you have a challenge experience, let me know. If you need a tissue, you need a drink. All of those things that nurses do. If we think about bedside nursing, we do those things. We're present with them during that time, oftentimes to encourage them to explore deeper, encourage people to do what is an eye mask. So their eyes are shaded so that way they can go and explore what's going on. And oftentimes also using some music that's there. So with the music, they have the headphones, they're listening to different playlists. The music often consists of things that are not in their native language. Because if it wasn't a native language, their mind goes to those places and it doesn't, that default mode network is being activated. So it's things that they don't necessarily recognize. And part of the with curating a music list is it can be ups, it can be downs, and it can kind of keep the session going and moving things forward for them to kind of explore and see what's going on. Real quick, I found if I don't talk about microdosing, the Q&A ends up opening up into that because people have had so many people who have asked that. It has zero to do with the fact of my book and what my experience with it. But patients are usually asking people about this more often. So microdosing is the act of taking 1/20th to 1/10 of a full dose of psychedelics. Often there's a little bit of a protocol there when people are doing it. So with that 1/10 to wrong button. That 1/20th to 1/10, what they're doing, if we start thinking about LSD being a typical full dose of LSD nowadays is 100 micrograms. Back in the day, that was off everyone's radar when they did the research. Actually, it was kind of interesting. Or when we start talking about full dose of psilocybin, it's typically the about 3.5 grams of dried mushrooms, which is referred to as an ounce. We're talking 1/20th to 1/10. So we're taking about 10 mics of LSD, 0.2 to 0.4 grams of mushrooms. A lot of people, and I say that because a lot of people now, when I started writing this, was everyone was using dried mushrooms, but now there's such an abundance of substances out there where people are getting mushroom candy bars and stuff like that. So many people are dosing and knowing what it is. So it's usually about 100 to 400 milligrams of edible mushrooms that people have. It does not alter their mental status. It does not turn off. It does not lead to these mystical experiences. If they end up going and microdosing and are chased by a dragon, that is not a microdose. They need to explore how they're weighing and exploring what they're doing with it. But the idea is that people can microdose and go on with their day. People can microdose and go to work. Many people will dose in the morning and have that like an SSRI type, but it starts having the improvement, but not being altered. They can be present in their family and working with them. Why do people microdose? People will refer to oftentimes as saying that they have better performances, having able to perform better, being able to have better cognitive abilities, thinking better, regardless if it's those cognitive slowings and stuff is because of depression or something else. Might be to relieve pathological conditions. So it could be because of pain. It could be some really good, interesting when people will do it because of having symptoms such as autism, having improvements with because of symptoms that might be neurodegenerative diseases, or to stop other pharmaceuticals or other medications. So that's why people will typically do it. I've shown you this already. The idea is it's still doing this in the same similar kind of way. We start looking at the microdosing people when people are doing it. They do have quite improvements often. I've had so many stories where people have told me just life-changing when they've done it. I had one person came up the first time I talked about it. Her husband had suffered a stroke 2 years prior. During that time, it was a left side stroke, right side was affected. He also had a history, he had temporal dementia. So whenever he became more anxious and more distressed, things got worse. Standard treatment, as we know, oftentimes people will end up being on SSRIs for that. But when he had the stroke, he lost all of the use of that right side of the body. He went through standard treatment, and his medical team said, if you don't have any more improvements at the end of the year, you're not going to probably have any more. He did not accept that. His wife definitely did not accept that. They went out and purchased mushroom candy bars online, started microdosing, and within a few weeks, regained the full use of that right side of his body. And she's telling me this in tears in a public appearance, and it blew my mind away. I get cold chills every time I think about it. Another individual was a woman I was talking to. She was telling me about her aunt who was on her way to a nursing home. She sold all of her belongings, sold her house. Within a week, she was going to be moving into a nursing home for the rest of her life, was the plan. She started microdosing, and during that time, and started seeing improvements to the point where I was like, how much improvement? Like, where was she doing? She goes, well, she sold everything, so she's homeless. So last time I talked to her, she was backpacking across Europe. Because she now had a lot of money from selling everything she owned going into a nursing home. And I know this is anecdotal evidence. This is like, N of one as I'm saying it. Holy shit. Like, oh my God. Right? So let's start wrapping up here to get to the questions and answers. One of the things I do want to mention here, there's some really good research out there with psychedelics and pain. Mentioned I've done really a lot of work with that. Part of the company I work with, PMAP Therapeutics, is with individuals who have chronic pain. This is not a radical idea. With this, the first study that was out was with this cast. He's the gentleman who was walking around the oncology unit dosing his people, but major improvements. Other study that came out was Kumaro, where it was a study done in Japan for individuals with phantom limb pain. And they did the early versions of the mirror box therapy with phantom limb pain while altering their mental status, and saw much better improvements with them for it. But it's also, there's really good research out there for people with cluster headaches. A lot of people, anyone seeing any patients who have cluster headaches, also known as suicide headaches, the community out there is hurting. No pun intended, I'm sorry for that. Because the standard treatments, they just don't have them. And they're very frustrated to the point where suicide rate is some of the highest because it's the most painful things that people have. One of the other individuals that have chronic regional pain syndrome, working with an individual with REMAP, and I can tell you this because we've been public with it in podcasts and interviews. This is an individual who retired early as a federal JAG judge, living with chronic regional pain syndrome for more than 15 years. She had a bunch of failed surgeries in her feet, bunion surgeries and such. She was falling a few times a day, going through standard treatment in and out of working with the VA and other places that she was working with. She also had been on ketamine for therapy with it. Her therapist, her VA staff said, it might be advantageous to go check out this with REMAP. She started working with us, did a 1-week session, high dose out in Colorado. Part of the REMAP is also working with physical movement, things like that. And the first day of her mystical experience as she was doing it, as soon as she was hitting the peak experience, she got up and started walking across the room on her tippy toes. She was not able to do that. They ended up putting a towel on the floor. There's an exercise where you scrunch your toes trying to pull it in. She was doing that. She could not move her feet before. That night they're driving to go get dinner. and she's sitting in the car, she's bebopping, playing the music, and she stops, starts crying, and partner Court goes, Lynn, what the hell's going on? Are you okay? And she's like, there's days I can't touch my leg because of the pain. I don't feel any pain. So when she hit that peak experience, her pain went to 0. I said she was living with pain for 15 plus years. She was living with chronic pain every day, 7 or 8 out of 10. There's days she couldn't put on her pants. They went home, they made dinner, she's eating dinner. She drops her fork and knife and starts crying again. Court goes, Lynn, what's wrong? She goes, I haven't been able to cut my food for the last 6 years. My wife has had to do it for me. She was cutting her food without even thinking about it because it just had to be done. And she's like, this is unbelievable. We're over 1 year out in talking with her. Her chronic pain is now she also has had symptoms of burning mouth syndrome that when it got worse, about 2 weeks after, 3 weeks after she came back, her chronic pain did come back because there was a lot of psychosocial issues of retaining wall broke and insurance wasn't paying it, all these bills. It shot up to a 0.5. 0.5 for her chronic pain, as opposed to 7 or 8. And when things go on, that happens. She also inadvertently, without a plan, detoxed off her Butrans patch because she forgot to bring one. She's also off of that, off of all of her other medications that she's on, that she was once on. And she's also just finished the Psychedelics Today Vital program to become a therapist. Unbelievable that she had, and this is a year later. She also had PTSD, which she was never diagnosed until she came and started working with us and seeing how much of those symptoms. But unbelievable. She had 2 more sessions that week that were high and doing more remapping with it, and just the improvements are there. So if you're interested in looking at the psychedelics and therapy pain, here's a couple of good resources for people to look at. Moving forward, I think we need to get better structured research. I think that we need to understand what's going on. And the biggest way to do that is having more availability, finding better treatments, having these conversations to decrease the stigma that's around it. I will tell you, I have these conversations with patients all the time. People often ask me, how do you do that? How many people talk about other substances with individuals, what people might be using, being opioids, alcohol, what have you? So part of where I talk about in my book is being able to, people are talking about these and people are coming and asking questions. It's okay to say, I don't know, or I don't feel comfortable. But with the moment that you say to them, you're going to fry your brain, is your brain on drugs, this and that, people know that this is not as dangerous or as scary as it can be. Yes, it can be dangerous. Yes, there's risks involved, but people are looking to go do and find these treatments. There's resources for you to learn more about it, and just saying to people, I know someone that could, here it is. But the moment you tell them and you give them the line that they're going to, fry their brain and never come back, you've lost them, and they're probably never going to trust you for anything else in your treatment with them because they've seen other things that's out there. In closing, your assumptions are windows to the world. Scrub them off every once in a while, otherwise the light can't get in. And progress is impossible without change. And those who cannot change their minds cannot change anything. These substances can lead to changes, which makes it really scary for some people. But at the same time, that's exactly what some people do need. Here's some more resources. I'm open to questions. Thank you.
Thank you very much.
On this microphone. I just want to say thank you so much. What you're saying here today is so important. Thank you. The momentum behind this was really exciting, and I also just want to ask, where do we send people? Are you practicing? Are you taking new clients? Where do we get people?
I'm in the process of setting up a private practice right now to be able to have more conversations here. Yes, that's where I'm trying. I'm starting to have that. I found it's the logical next step in my progress. But there's also the individuals out there that like the Psychedelics and Pain Association, MAPS, things like that. There's a one of the things I didn't really go into too much was mentioning the fact that people are doing these on the underground. And I think that's the thing to also kind of realize that's there. And it's a lot more than what people might think. It's a hell of a lot more. There was a study with microdosing where they looked at people who asked them, did people ever talk about with their providers, and only 20% said they did. I have lots of people who reach out to me that said, I don't know if I can talk to my provider about this, but can you? Can you talk about this? Can you answer these questions? The underground is thriving, and get on my soapbox for a minute. Access is important. You know, if and when we start seeing these substances become legal, who's going to access these substances and these treatments in a legal manner? It's people that are insured, people that have money, and people that have ways to go do it, and finding people to work with. I will tell you, during CIS, I was talking with a nurse, became friends with her. She was a nurse. She was working ICU nurse. During COVID, her symptoms of depression got worse. She knew she needed to get back onto one of her medications. I think it was fluoxetine. No provider were taking patients during COVID, and here she is working as a nurse in healthcare with insurance. She couldn't find access, so she ended up going out and starting to grow mushrooms and started microdosing. She's happy she did. She had better improvements than she ever had. But here's someone trying to access it and not access anything other than feeling better and addressing her depression that she had lived with and successfully treated really well prior. She couldn't access it. So my fear is as this becomes available, people are not going to have the ability, and that's kind of where, you know, I'm not condoning the sale, illegal, whatever, all of that, but people are going to do what they're going to do, and they find ways to go out and access mushrooms. They end up spores are legal in 47 states. People will go and look at how to grow. Once it becomes growing, then it becomes illegal. But people are doing that. And I mentioned in my book the number one most dangerous side effect with microdosing specifically is the legal consequences that come with it. I testified for a nurse in Indiana that got caught microdosing because of the amount that grew was, I don't want to say a large amount, but the eyes of the state said it was a large amount. She was looking at trafficking narcotics for it, and her house the door got kicked in by DA agents with ARs and hazmat suits because they were afraid of the spores in the air populating and infecting them. And part of the testimony where I said is I looked at the amount that she had and said, you know, this is no different than me prescribing sertraline, 50 milligrams, 2 tabs times 90 days times 4 refills. The amount that she had was a year's worth of personal use meds of her medicine, and she wasn't sharing it. And she ended up getting it reduced down to a misdemeanor. Took a year and a half to her fighting to get her license back. She actually just got it back about 2 weeks ago. She also is working, just finished the Psychedelics Today therapy program to become a psychedelic therapist. She was a neonatal nurse. And the other part of this was she was also trying to get treatment with medications. None of them had ever worked. It was that for the depression, she did therapy, she did Actine, she did ketamine therapies. And she went as far as it was going to go into doing ECT, but where she lived in India at the time, there was no access to it. There was more than 2.5 hours away, which isn't feasible when someone's starting ECT, let alone the side effects of the mental clarity and forgetfulness. So, I mean, this was something she went out there and she risked what she had improvement of it. So people are desperate for it, which is where if we can start getting these changes and having access, just being legal is, I don't think, enough. That's why I'm also part of doing the decrim research legislation, trying to push for that because people want to be able to feel better. That answer your question? Okay, I was on my soapbox. I'm sorry.
That's okay. I think this is super exciting and thank you for talking about this and doing what you're doing. This access to it is going to be important. And so we can contact you here through this contact.
Yeah. Yeah, my website, my Facebook is another, my email's here, and my Instagram is actually now at the Entheonurse. Use that 2-factor. Someone stole it, and I wasn't able to get my other one back. So protect yourself in that manner.
We only have 1 minute left, but I think we have time for one quick question over here.
And I'll be milling around so for a little bit so people can ask, which is usually when people want to talk.
First, I want to know where you guys sure.
Hello, Bean.
Second is, you work with any tribal communities?
I don't directly at this time, but also I live in the capital region. We don't really don't have a lot to have. I would love to.
Interested?
Yes, honestly.
We got one question from the chat here. So where do we refer people to or send them for more information if we're in Maine? I assume insurance does not cover any of this. And do all people have to go out of state?
Me, sometimes insurance will. That's where I'm part of with setting up my private practice is you know, I will not be able to provide people with it. I'm hoping to be able to offer ketamine as things go in or with Spravato as such. But there's also where I said the underground is there. I don't want to, I get stuck in with the point of I want people to feel better and they're going to go do it. There are places, there are people. I work with some underground people when their patients come and say, hey, I'm going to do this. Can we talk about my meds? Can we look at that? Yes, I can. I'm not going to refer you to them, but I can't do that. But there's breadcrumbs out there where people can search things up and kind of find out. So.
And just to clarify, right now it's only legal in Oregon and Colorado. So I want to give a big thanks to CJ for coming and talking about this conversation. He is going to be here for a while. If people have other questions, we can sort this stuff, but now we're going to go on break until 10 a.m.